question regarding negative symptoms. Typically, what would you add to at least decrease it a bit, like not to treat it? Do you typically add SSRIs or any other pharmacology?
For the boys, the question is, do I augment the medication for schizophrenia for the negative symptoms by SSRI or any other medication?
Yeah. If you look at the guideline appendix, there is an entire section on SSRI efficacy for negative symptoms. If you define it strictly as negative symptoms, and you say it's emotivation and apathy and so on, and for that you're giving SSRI, there is no evidence that it is effective. I suspect in practice what happens is people diagnose an additional depressive disorder, or you phrase it as schizoaffective disorder, which then means those studies get excluded from the schizophrenia guideline. And that is less of my evidence-based speak and more of routine practice. So in practice, if you are very clear that maybe there is a depressive element, it would be prudent and in fact indicated to give almost an empirical trial with 6 weeks of antidepressants.
Okay.
The risk is whether people just accumulate drugs. You see, they're already on 1,500 equivalents of chlorpromazine, and then they get an SSRI, and someone tries a combination, and so on. So if one is systematic about the rationale for introducing, then remember to take it off as well. Then that is something that you will be guided by your intuition as a clinician rather than
Can SSRI aggravate psychotic symptoms?
during an acute relapse.
There are new data about the use of fluvoxamine, particularly fluvoxamine, in schizophrenic patients.
Yes. I mean, for several years it used to be conventional teaching. I mean, as a postgraduate, you would fail an exam if you diagnose someone as a depressive or a bipolar depressive disorder when he was actually a schizophrenia, and the professor's justification always would be, you just made a schizophrenia worse. I suppose again in practice, if it is more of a schizoaffective kind of picture, then you're going to treat with an antidepressant plus an antipsychotic, which effectively would be no different than the treatment of a psychotic depressive disorder. So I would struggle with thinking a scenario where a straightforward schizophrenia is misdiagnosed as a straightforward depression and therefore completely wrongly treated. It could happen, but I think that would be less likely. So the risk of the active symptomatic worsening in clinical settings would be less if you also have the antipsychotic cover. I think the much bigger risk is misdiagnosing either a developmental disorder or a personality disorder and aggressively treating it. So what you consider intractable schizophrenia is actually a developmental disorder which was wrongly diagnosed. And I did look at epidemiological data for the prevalence of some of that from non-Western settings. And for the developmental disorders, there's very limited data from